All right. All right, let's get started. Excited to be here.
All right.
Yeah, let's do it.
Farouk, how are you? Haven't seen you in a while. All right, let's do this. Welcome. Good morning, depending on where you join us from. It's uh, it's been really cold and a snow day here in Philadelphia. So, um, but we are excited. This is our seventh round of the case competition. The second time that we go to Asia, Oceania, and we have awesome uh, list and of cases that are very, very well presented and very unique. So but before we start, again, we're gonna thank our institutions that back us up in these endeavors: the Children's Hospital of Philadelphia, Penn Radiology, and of course the Center for Global Health of the School of Medicine. And we are going to introduce our keynote speaker right away. Farouk, please do the honors.
Yes, we're very honored to have Dr. Mingmar Sharper with us today. Thanks to our introduction from our colleague Harry Jha, who was just with him, with a team from our institution not that long ago, and was very impressed with the work that they have been doing. So we are again happy to have Dr. Mingmar Sharper over here. Dr. Mingmar Sharper is the only the first physician from his community who went ahead to do a lot of work with the Ministry of Health and has brought back ultrasound services to the rural indigenous community to improve prenatal care. So today we're going to hear about his work, and he has to leave right after to catch a flight to I'm sure he has to be somewhere to do some good work. So let's jump straight into it and hear from Dr. Sharpa.
Hey, Dr. Sherpa, if you can go ahead and share your screen.
Yeah, I will do that. I cannot find my screen. Just a minute. Share the screen. Yes, here it is. I don't know where it is now. I think before. Yeah. Oh, I'm so sorry. I have to catch a plane to train 12 nurses. They are waiting for me. So it is a remote place. So I have to catch this plane. There are not many planes, but one plane I have to catch today. There's only one flight. So I'm sorry for this, but I will start. Thank you so much, everyone. Thank you so much. This is Namaste. It's kind of a greeting from Nepal. I'm presenting this. I'm not a radiologist. I'm a village doctor. I was in my village for a long time. So many years, 24 years, and during my work in the village, I found out that maternal mortality is one thing which is very important, which can be prevented, but still we were not able to prevent because of various difficulties in the developing world. So I came up with this I designed my own little project for the village. So I called it Solukhumbu. Solukhumbu is my district. So I call it Village Ultrasound Project. And in Nepal, women die on the road, not on the way to hospital. They have to walk 3-4 hours, 2-3 days also. So when they have labor pain, they start walking to hospital, and they deliver on the way, and so many women die. And this is one picture, but there are so many of them. Nepal has the one of the highest maternal mortality in the world. Is thought of having introducing ultrasound training to the nurses, because in the rural hospital and also in the rural villages, village health clinics, we call it health post, they don't have doctors, they don't have radiologists. So the only way was to train nurses how to do ultrasound, especially obstetric ultrasound, and they will find out abnormal conditions of pregnancy, whatever they can, and they will refer to hospital on time. So that is the only way. There is no other magic or no other way to save lives. So I thought that we, with the help of Planned Parenthood, West Washington, and Sonosite USA, they were very kind to donate one ultrasound, one hand carry ultrasound, little ultrasound machine to the hospital. And with that, I was able to train some. They helped us to train the nurses also. So we trained our nurse for 3 weeks. Ultrasound is not easy to train to nurses, but still we did so. And with the help of a hand carry machine, after the training, I sent these nurses to pregnant women house, and also to health posts from time to time, so that once they find some abnormal conditions of pregnancy, will refer to hospital on time. That was the only way. So uh, uh, at the same time, we had the Radiologist Association in Nepal. They were objecting the training. They say they were not happy with the nurses being trained for ultrasound, and they are still, even after started more than 15 years, still they are objecting. But I could not stop. It is a matter of life and death in the village, and we don't have radiologists in the village, so there's no other way. So they were afraid of, the radiologists were afraid of losing their bread and butter. So so it was very difficult, but still I continued. And this is 15 years after since I started. And this is the first training long back in my village. I could not train in Kathmandu or big cities because the radiologists were there. So this is my little village hospital where I invited the American radiologist trainer, the ultrasound technician. I requested them, and they trained our nurses. Different villages, very remote villages in Nepal. And this is how we we trained this for 3 weeks. 3 weeks training is not enough, but we did a kind of crash course. And those days we were very lucky. The ultrasound, this is so small. Hand carry ultrasound. The Sonosite company they had developed this ultrasound machine. And after the training, we sent the nurses to villages. See, find the pregnant woman and give an examination, and if they find something abnormal, they will refer to hospital on time. This is how we started 2008. And in the village, once they are diagnosed, like this couple, they have never ever seen a hospital. But when our nurse went to their home and found this twin pregnancy, and then she referred them to the lady to hospital, and where we had done cesarean section, and now they are happy with these two babies. So this is just one example. But there are hundreds and hundreds of them like this. And those days, this is a very old slide, that before ultrasound introduction and after ultrasound introduction, I showed some slides to the Ministry of Health people. So this way, the cesarean section also increased, reducing the death at the villages. This is very old slide, but still just for reference, I wanted to show it. And we had the government officials visiting our hospital, and they were checking whether the nurses were doing good, whether it was really good, or whether it is useful. But still, the Radiologist Association was so strong that the government could not implement it in the whole country. But later on, government got convinced that it is really useful. So at that time, this is a small conclusion that I had drawn then, long back. So nurses from remote health posts, when provided training in focused obstetric ultrasound, they can save women and newborn lives by detecting abnormal conditions of pregnancy and referring them to hospital on timely. So after that, we started training nurses in a bigger hospital, and this way, this is not easy to train nurses because they need a lot of exposure, and it was very important to train them very nicely, so that they can really perform they can do confidently in the village situation. So this is how we took, this is 21 days class, hands-on and theory combined classes in the village. So after 21 days, we provided them kind of certificate, but it was very strict that they cannot determine sex. There is no way. We never taught them, and we also told them that it is strict, very strict. They cannot detect sex in the ultrasound, and they will be their license would be seized immediately. The court can file case against them, and they will be in trouble. So it is very strict that we never taught them how to detect sex, and it is very strictly prohibited. So this is just an example, and we have trained after 21 days basic training. We followed up them, or every nurse, every student whom we trained, every batch, they were kept on there's a messenger group. We have messenger group. Whenever they have any doubt, they can always call us. They can always show video us and get the information, get help. So we gave this follow-up for a long time. But after 6 to 8 months, we did a refresher training to each of them, so that they can come back and they will tell us their problems, and we try to resolve them at a bigger hospital with many different abnormal cases and like that. So we did everyone whom we trained, we did a refresher training also, 5 days refresher training. And after 5 days refresher training, they were quite confident, and they did a lot of good work. They were quite confident. They did not need much more follow-up later. So with the training, when the nurses are trained, they find out normal or ectopic pregnancy. They can diagnose multiple pregnancies. They can diagnose fetal age and expected delivery. They can tell abnormal presentations, placenta previa, placental abruptions, polyhydramnios and oligohydramnios, and IUFDs, molar pregnancies, and other anomalies. These are just few, but these are really life-threatening conditions, and high risk pregnancy, and once they find anything abnormal, they will just refer to hospital, and whatever has to be done would be done by the proper specialist at the hospital. The hospital is usually pretty far, very, very far. They have to walk. So timely referral is very important. That is what we focus. So that's the only way. So we trained nurses. So we kept on training, and training like that for many uh, for many batches. We kept on training for many batches, and then as a result, we had, these are the more than 100 nurses. We had a review group. So we did a review, and their findings were very highly appreciated by the provincial authority, and it was very useful, very, very useful. So uh, recent survey from the government, they found out that this is the far west, where we trained all the nurses from this province. All this province used to be one of the highest maternal mortality rate before. And this is Kathmandu. Bagmati is the national capital. This is the lowest, and second lowest is the Sudur Paschim, the far west province. It is because of this ultrasound training. Everyone knows that this is because of this ultrasound training to the nurses. So after that, government has realized that this kind of training is useful. So now after so many years, after more than 15 years, now the government is very strong, and they believe, and that's why they are supplying ultrasound machines to other provinces also, where there are very high mortality rates. So this has become very it has convinced the government, and we're very happy. We would like to work more. And after that also, I've trained these nurses again, because Nepal has many remote villages, and they are really suffering. And so some donors were, they liked the work, and they were happy to donate ultrasound machines to nurses from the remote villages. This is just one batch we did about 6-7 months ago. It was donated by one German organization. So we distributed 12 machines. We trained in a batch of 12 nurses, 12, and they distributed, they gave 12 machines. So we were very lucky. We also, not only in the village, not only in the remote villages around Kathmandu. Now we are in Kathmandu and big cities also. The poor women has to go to hospital 6 or 7 times during a pregnancy for ultrasound examination. They have to pay for taxi, going there, coming back, and also for the hospital. To hospital, they pay 12 to 1,500 to 2,000 rupees, which is quite a lot of money for them, and it is very difficult. And the big hospital, they have to be in queue. There will be 100 floor waiting for the ultrasound examination. So now we are providing, we're sending our nurses to the health post, and they get their ultrasound examination right at the health post. And sorry, we were very lucky. During one such visit, our Dr. Saurabh and Dr. Abbas and his team was there also during one of our visit. And this we started in one place. Now it is in 12 health posts around Kathmandu. So we are going there regularly. Every month we send our nurses. I go myself, and I also send our staff to do ultrasound there for free. I feel that ultrasound and every treatment for pregnant woman and newborn up to 6 months should be free. And I'm really fighting for this. And ultrasound, I would like to introduce this ultrasound to all the health posts so that the women get free service and they get safe. Their pregnancy becomes safe. And I was very lucky to have to know Dr. Saurabh and Dr. Abbas, and I'm very much grateful to them, to all. And here, this is a small presentation from my side, and I will keep working. I have retired since 10 years after I finished with the government. 10 years I'm working on this, and I will keep working on this because this is very important field of work, I feel. So I would like to thank you so much for your time and for giving me the opportunity to make this little presentation to you. And as I said before, I have to catch a flight, and I would thank you so much for giving me this time and to this. Namaste, that's all.
Namaste. Thank you so much, Dr. Sharpa, for your excellent, insightful presentation and sharing your inspiring work with us. I know you have to leave soon, so if there are any questions for you, we can have Dr. Abbas and Dr. Follow up with you.
Yeah.
But thank you so much for your time.
Thank you. Namaste. Bye. Thank you.
Yeah.
I will leave you.
So,
Thank you.
Fantastic. Mo, since we have 7 minutes left in this time slot, I'm wondering if Abbas and Harry had any comments that they maybe wanted to make, just to echo the points that were made and talk about potential role of POCUS and ultrasound training, maybe for the next 5 minutes.
Oh, I think we will need to.
Okay, can you hear me, Farouk?
Yeah, I can hear you.
Now we can.
Yeah, I think the chap is quite extraordinary, very modest, and what he's achieved in terms of reduction in maternal mortality and morbidity is a big treatment effect, something that at a population level is much more than can be described at an individual level. So when you multiply what has happened, it's a big effect. I think when we went there, myself, Abbas, Stephen, Rebecca, and Winston, one of the things we understood was that if, as a radiologist, you want to make an impact in LMIC, then what you want to do is you want to build expertise there, help build expertise there. And what they're really asking for is expertise in ultrasound. It's a shame that we've stopped scanning, because that's the one skill that they're actually looking for. CT scans are fine, but it's the ultrasound that actually is the toolkit of the rural radiologist. And that's really the message I would want to give to anybody interested in this outreach.
Fantastic. Thank you. Abbas, anything you want to add, or should we move on?
No, thank you. Can you hear me?
Yeah.
Yeah, no, Dr. Mingmar is impressive. I look up to him. I know he put in the disclaimer that he's not a radiologist, but it underscores the importance of innovating when we come across challenges such as the ones that he experienced with issues with maternal and child health. When we were there, we went to 2 sites with him, and over the course of our time with him, we scanned 80 patients, approximately 80 patients, and we emergently referred 5 to hospital services, and that comes out to about a 5% rate, which, when you consider the environment in Nepal, is quite significant. You can be, just an hour by distance from, any major city center, but given the terrain, it's extremely difficult for people to move around. So being able to provide the service, Dr. Mingmar is impacting countless lives. And as a pediatric radiologist, I think it's important to remember that, ultrasound at that stage is also in our wheelhouse, right? I feel like, that is also taking care of children. It's not quite fetal ultrasound in the sense that we practice at CHOP, but I also strongly believe that this is something that we should continue to work with Dr. Mingmar to improve the training programs that he has available to potentially help with any equipment needs and so forth. So in the coming months, my goal is to, in collaboration with Dr. Mingmar and Dr. Jha, to apply for grants to support his initiative, and hopefully we can fund it.
Awesome. Awesome. Cool. Well, thank you for the comments. We have 3 minutes left. We can move on, or if anyone else from the panel wanted to say something before we pass it on to Mohammed to kick things off. And so I'm looking
Yeah,
at
no, let's just do that. Let's get us started with the awesome cases that they submitted. But I agree both with the premise and obviously with the results that and we are supporters of point of care ultrasound for non-physicians, especially in the rural areas and in areas where reaching a radiologist is or the radiologists are not available. So anyway, moving on, we're gonna have Mohammed take it over with some of our initial cases.
Hey everyone again. So we have a very impressive and very interesting list of cases today. We had a lot of submissions this cycle. We had almost 60 cases submitted, abstracts submitted. We had to, unfortunately, narrow it down to just 20 finalists because this is how the competition goes. So we're gonna start with our first submission from Sir Gangaram Hospital in India, from Dr. Pradeep Chaurasia, presenting a case of recurrent pancreatitis in a young adult. So let's start.
Hello everyone, I am Dr. Pradeep Chaurasia, currently pursuing my DNB in nuclear medicine from Sir Gangaram Hospital, New Delhi, India. I would like to avail this opportunity to express my gratitude to my mentors, Dr. Ritu Verma, Dr. Ethel Shangle Bello, Dr. Piyush Ranjan, and Dr. Nikhil Senyare. I would now present my topic for today, which is perivascular parathyroid adenoma as a rare case of recurrent pancreatitis. I have no conflicts of interest to declare. Ectopic parathyroid adenoma can occur anywhere from the angle of mandible to pericardium, out of which mediastinal location amounts to less than 5% of ectopic locations. Pre-surgical localizations with nuclear medicine techniques has a very important role in improving the success rate of surgery, for which nuclear medicine techniques such as system scintigraphy and fluorochromic PET-CT has been shown to be very useful. I will now present a case of 23-year-old male patient who complained of increasing weakness, fatigue, stomachache. He had prior 2 episodes of similar complaints for which he was managed conservatively. On biochemical investigation, he was found to have elevated amylase and lipase levels suggestive of pancreatitis. On further investigation, he was found to have elevated serum calcium, which was 17.2 milligram per deciliter, and elevated parathormone level, which was 300.4 picogram per ml. Thus, a provisional diagnosis of primary hyperparathyroidism was established. For treatment workup, pre-surgical imaging was planned. Dual-phase, dual-time technetium 99M system parathyroid scintigraphy was performed, which showed a focal area of increased tracer uptake in the left side of anterior mediastinum. in the early images, which was persistent even on late images taken at 2 hours. This focal activity was suspicious for ectopic parathyroid adenoma. However, in view of unusual location, fluorocholine scan was requested. Fluorocholine PET-CT was performed at a later date, which showed a fluorocholine avid nodular soft tissue in the anterior mediastinum, just the bifurcation of left common carotid as well as left subclavian artery. As you can see in by the arrows marked, there is a fluorocholine avid lesion just at the bifurcation level in the coronal images on the right side and in the axial images on the left side. So, which after this, the patient was planned for the surgery. Video assisted thoracoscopic surgery was planned, and the parathyroid adenoma was removed. Subsequent histopathological examination of the surgical specimen confirmed the presence of parathyroid adenoma. Post surgery, the parathyroid there was significant improvement both clinically and the lab findings of gradual normalization of serum calcium and parathormone levels. So, we now discuss the role of parathyroid adenoma localization. Ectopic parathyroid adenoma can occur from anywhere to angle of mandible. However, mediastinal locations amount to less than 5% of the ectopic. So nuclear medicine scintigraphy with a system-based scan is useful. However, has its disadvantages like low sensitivity in very small parathyroid lesions due to poor spatial resolution in post-op patients with thyroid adenomas or when present in close proximity to the thyroid. Also, system AV is inherently negative in one-third of the patients with adenoma. Therefore, fluorocholine PET-CT has shown to be superior imaging modality for localization, especially in biochemical hyperthyroidism who are system AV negative on the previous imaging. So, fluorocholine PET-CT may be considered as the first imaging modality in suspected primary hyperparathyroidism. However, cost and availability remains a limiting constraint. These were the references used by me. You can also search at a later date. Um,
That was our first case. That was a very interesting case from India. So as I was saying, we had 20 cases. We have 20 finalists from different countries in Asia. We have cases from the Philippines, cases from India, from Vietnam, from Pakistan. So to take it to the next case, it's a case of OEIS complex presented from the Philippines.
Today, I am Dr. Justin Damian M. Malubay from the Department of Radiology, University of the Philippines, Philippine General Hospital, Manila, Philippines, together with my advisor, Dr. Rovinino D. Saavedra, and co-author Dr. Clarice Dayan C. Cayetano. I'll be discussing the case report titled When It Rains, It Pours, a case report on a patient with OEIS complex with a multitude of other concomitant malformations. So this is a case of a Filipino newborn born preterm 34 weeks AOG with initially indeterminate sex due to ambiguous genitalia with associated multiple congenital anomalies, omphalos, lumbosacral mass, imperforate anus, and ambiguous genitalia, who was admitted under the pediatric service of the Philippine General Hospital in March 2023. Multisystemic medical problems, including intubated status and hemodynamic instability, were encountered during the admission, leading to difficulty in transporting the patient for imaging studies, hence only a cranial and abdominal CT scan was obtained. Further deterioration of the patient's clinical status led to the patient's family signing advance directives and do not resuscitate and discontinue further diagnostics, and the eventual demise of the patient in less than a month of admission. Medical autopsy and postmortem MRI were offered to the family, but no consent was given. Our patient has ambiguous genitalia and was initially assumed to be female. Karyotyping showed otherwise XY chromosomes. Bladder cloacal exstrophy is seen in the figure, with ambiguous genitalia clinically apparent as seen as a protrusion from behind. There was no distinct anal opening, confirming our diagnosis of imperforate anus. As with the different cases of OAIS complex reported and written in literature, the patient similarly presented with a complete set of malformations. The omphalocele is visualized in CT scan as an imperceptible abdominal wall musculature with an anterior wall defect covered by a thin membrane, as seen in the figure. The entire liver and its accompanying vessels, gallbladder, and some bowel loops are seen herniating through the said defect. Posterior spinal fusion defects were likewise seen, with the lower thoracic and lumbar vertebrae seen as an exophytic cystic mass continuous with the spinal canal, and with the herniation of string-like soft tissues which may represent dystrophic neural elements seen in the figure. Skeletal anomalies will also present in our case, with the pelvic bones appearing small and the widened interpubic distance consistent with the classic finding of symphysis pubis diastasis and bladder exstrophy. Sacral agenesis was also present as evidenced by the absent lower sacral bones. Spinal fusion defects as well as lubosacral mass are a necessary part of the diagnosis of OAIS complex. The CT scan was also used to assess for CNS abnormalities. Our patient was also found to have Chiari-2 malformation as evidenced by the low-lying torcula of Herophily, fullness of the foramen magnum, and ventriculomegaly. Among the 27 reviewed cases in our extensive English literature review, only one case was present with Chiari-2 malformation, while 10 had Chiari-1. An incidental finding of bilateral renal ectopia is seen in our patient. The figure shows the left kidney below the left hemidiaphragm with minimal intrathoracic extension displacing the spleen. The right kidney is found in the right aspect of the pelvic cavity with the renal hilum oriented posteriorly. A coronal reconstruction of the CT scan of our patient showed the small bowel loops predominantly in the right hemiabdomen and the large bowel loops predominantly in the left hemiabdomen, as well as abrupt turning and persistent narrowing of the duodenal segments consistent with mid-gut malrotation and with secondary gut obstruction. Among the published cases of OAIS, malrotation was present in 3 out of 27. OAIS was originally described as a vesiculo-intestinal fissure. Improvements in imaging modalities led to association with spinal dystrophism. Incidence worldwide is 1 in 200,000 to 400,000 live births. In our extensive literature review search, if our ratio concerning OAIS and the different concomitant malformations hold, our patient has a 1 in 20 million chance of having the disease entity of OAIS plus ambiguous genitalia, Chiari-2 malformation with lumbosacral myelomeningocele, ectopic bilateral kidneys, mid-gut malrotation considering caudal regression syndrome. This is the first reported case of OAIS complex in Philippine scientific literature and possibly the first with the entire multitude of other concomitant malformations. While we could have gathered more details with the use of other diagnostic modalities such as MRI or ultrasound or even fluoroscopic evaluation, it is imperative that we take into consideration the circumstances surrounding the situation of our patient. With the unstable state of our patient coupled with the limitations of our intensive care units and diagnostic facilities, as well as most of our patients are economically challenged, we have to accept that we might not be able to make use of all the modalities, but learn to make do with what is available. In this case, the CT scan was able to provide us with an abundance of information for the evaluation of our patient, emphasizing the role we have as the experts in diagnostic imaging to provide the best service we can to our patients by prioritizing the imaging studies that will give us the most useful information. That is all. Thank you, and these are my references.
Thank you for that interesting case. Extreme images and very expressive imaging findings. Moving on to our next one from Nepal. Dr. Kabiraj Bhusal will be presenting a case of disseminated cysticercosis.
Hello all, warm greetings. I am Kabiraj Bhusal, a third-year radiology resident at Tribhuvan University Teaching Hospital, Kathmandu, Nepal. Here is a case of a disseminated cysticercosis, which was an incidental finding in a patient with obstructive jaundice. A 50-year-old gentleman from the low-middle socioeconomic class presented with history of obstructive jaundice in our center. The patient was subjected to contrast CT of the abdomen and pelvis, which revealed distal cholangiocarcinoma. It was treated with the stomach-preserving pancreaticoduodenectomy. Incidental cysticerci were also detected in the abdominal CT images. Patient also had a history of the seizures for which he has never sought treatment before. Neurology consultation and imaging were done, which revealed neurocysticerci and anti-epileptic drugs were started. The patient is doing fine now and is seizure-free and without any evidence of tumor recurrence. This is the coronal reformatted images, which shows the enhancing growth on the distal part of the common bile duct with upstream dilatation of the common bile duct as well as the both right and the left intrahepatic bile ducts. In this image on the right, there are multiple cystic lesions in the cardiac muscles with presence of a high density scolex within some of these lesions. The lesions along the left dome of the diaphragm show ring enhancement on post-contrast images. These are the coronal reformatted of the back on the left and the maximal intensity projection image on the right, which shows cystic as well as calcified lesions directed along the fibers of the muscle fibers, giving the rice grain-like appearance. These are the axial CT images through the liver and the lung, which shows hypoenhancing granulomatous lesion in the liver as well as the lung. The lesion in the liver is, unlike the dilated intrahepatic bile duct, is discontinuous and is not traceable like the intrahepatic bile ducts. These are the T1 sagittal, T2 axial, and the flare axial images, which shows the multiple cystic signal intensity lesions in the brain, which shows the T1 high, T1, T2 low, as well as flare low signal intensity scolex within these cystic lesions. The lesions are distributed in the thalamus, pons, soft palate, tongue, as well as in the orbital muscles. These lesions show predominance towards the region of the gray-white matter junctions, giving the starry sky appearance. The lesions are also seen in these orbit as well as extraocular muscles. In this DRE image on the right, some of these lesions shows blooming foci within, which are suggestive of lesions in the nodular calcified as well as calcified stages of the lesions. Some lesions in this T2 weighted images show surrounding perilesional edema, which is suggestive of the lesions in the colloidovesicular stage, whereas some of these lesions does not show any perilesional edema around them, which are suggestive of lesions in the vesicular stage. These are the CT axial images, which shows the cystic as well as calcified lesions distributed in the cerebral as well as cerebellar hemisphere, as well as some lesions in the subarachnoid spaces as well as in the orbit. ACC may be parenchymal, subarachnoid, intraventricular, or mixed. The racemose variant is uncommon and may be large, multilobular, and clustered. Atypical presentation can occur in our, just as example in our cases, but the common pattern is a patient presenting with a seizure in the endemic area, especially those who are more than 20 years of age. The stages are given by the Escobar stages, which includes the vesicular stages, where there is a cyst with the scolex without any perilesional edema and without enhancement. In the colloid vesicular stages, the cyst shrinks with ring enhancement and the perilesional edema. In the granular nodular stages, the cyst shrinks further with decreasing enhancement and the edema. In the nodular calcified stages, calcified lesion is seen. The most important differentials in our setup is the tuberculoma, which usually presents with T2 low signal intensity lesions and is slightly larger than that of the NCC with absence of the scolex within. Marked perilesional edema is common with lipid lactate peak on the MRS. Other differentials includes the abscess, which shows thin and regular rim enhancement with central diffusion restrictions. The metastases are quite common in more elderly population, which shows the disproportionately large perilesional edema. And MRS shows the choline peak within the tumoral region in the metastatic lesion and normal outside in the adjacent edema. The neoplastic lesions like GBM shows thick and nodular peripheral enhancement with peripheral diffusion restriction, and chemophatic demyelination may be rarely encountered, which shows incomplete ring with the open end towards the cortex.
An informative case with multiple images. I would like to remind you to please invite your friends, because as you, if you have already been in one of our cases competitions, we have a voting section by the end of this, by the end of displaying the presentations. So if you invite your friends, they can vote for you and you can be up to win the People's Choice Award. So now moving on to another case from the Philippines. It is presented by Dr. Jazril Botation presenting about Chiari-2 malformation and thoracic myelomeningocele. Let's see.
Good day. I am Dr. Jazril P. Botacion of the Philippine Heart Center Cardiovascular Radiological Sciences Division, and with the guidance of my mentors, I am here to present a unique case of Chiari-2 malformation with coexisting anterior and posterior thoracic myelomeningocele in a 2-year-old girl. Myelomeningocele is a common congenital malformation associated with Chiari-2 malformation in 95% of cases. However, anterior thoracic myelomeningocele is an extremely rare congenital anomaly, with only 4 cases being reported in literature, none of which coexists with another spinal dystrophism. The case presented is that of a 2-year-old female born to a G1P1 mother with regular prenatal visits, irregular intake of folic acid, prenatal history of treated urinary tract infection, and unremarkable first trimester ultrasonographic findings. The patient presented with dorsal upper thoracic mass at birth, enlarging head circumference, inability to walk at 2 years of age, and a prior chest radiograph finding of persistent left lung haziness repeatedly treated as pneumonia. Outpatient MRI of the thoracic spine showed a large CSF and spinal cord filled sac herniating through a butterfly vertebral defect. This is an anterior thoracic myelomeningocele which presented as persistent left lung haziness in chest radiographs. There is likewise posterior herniation of a CSF and spinal cord filled sac through a posterior osseous defect at the level of T1 vertebra. Absence of skin covering this posterior myelomeningocele was noted. This corresponds to the posterior upper thoracic mass noted at birth. MRI of the brain showed Chiari-2 malformation consisting of a small posterior fossa with downward sloping of the tentorium, low torcula, and associated herniation of the medulla, fourth ventricle, and cerebellar vermis through the foramen magnum. Tectal beaking with loss of CSF signals in the sylvian aqueduct causes obstruction at this level, resulting to marked dilatation of the bilateral lateral ventricles and third ventricle. There is likewise marked thinning of the corpus callosum. Patient is due for referral to other specialists on her next consultation for further assessment and treatment planning. Chiari-2 malformation is characterized by a myelomeningocele and a small posterior fossa with displacement of the brainstem, cerebellum, and fourth ventricle through the foramen magnum. It occurs due to in utero malformation of the spine and cranial structures. It has been proposed that the underlying cause of Chiari-2 malformation is the presence of an open spinal dystrophism such as myelomeningocele, which causes redirection of CSF flow, resulting in a fourth ventricle unable to maintain distension. This eventually leads to a hypoplastic posterior fossa and cerebellar tonsillar herniation. Spinal dystrophisms such as myelomeningoceles often occur sporadically and non-genetically, but among other factors, maternal folic acid supplementation has the most potential in its prevention. Defects in the complex process of spinal development during embryogenesis may result in incomplete closure of the posterior spinal elements and eventually dorsal spinal dystrophisms. As early as the second trimester, myelomeningocele and Chiari-2 malformation may be detected via fetal sonography. Postnatal MRI aids in the diagnosis and allows for better visualization of the spine and associated anomalies, as well as prognostication. Anterior thoracic myelomeningocele through butterfly vertebra coexisted with posterior myelomeningocele as part of Chiari-2 malformation in our patient. Multiple coexistent spinal dystrophisms may equally represent distinct overlapping events or a more complex pathology during embryogenesis. Socioeconomic factors cannot be discounted in the development of the patient's condition since it largely affects maternal nutrition, more specifically folic acid supplementation. Early diagnosis with careful fetal sonography and postnatal MRI combined with interdisciplinary multi-stage approach to surgical management is essential to prevent neurologic decline and reduce risk of complications. In summary, presented is the first recorded case in English literature of anterior thoracic myelomeningocele coexisting with a posterior myelomeningocele as part of Chiari-2 malformation. With that, I end my presentation. These are my references. Thank you for listening.
A very rare case.
Good day. I am Dr.
A very rare case from the Philippines. Very informative with very nice explanations. Moving on to our second one from India, Dr. Jerin Sekar will be presenting about acute necrotizing encephalopathy of childhood.
Good evening. I am Dr. Jarin Sekhar from the Postgraduate Institute of Medical Education and Research, Chandigarh, India. I'll be presenting two cases of acute necrotizing encephalopathy of childhood, ANEC, a disastrous neurological manifestation of dengue fever. The first child is a 11-year-old boy, Master H, who presented with fever, seizures, and altered sensorium for 4 days. He belonged to a rural area of India and was from the lower socioeconomic class. On examination, he had an unstable airway, bradypnea, a Glasgow Coma scale of 5/15, decorticate posturing, papilledema, and brisk reflexes, all suggesting a raised intracranial pressure. Lab findings showed severe thrombocytopenia, elevated serum transaminases, elevated C-reactive protein, and procalcitonin. Etiological workup was suggestive of dengue fever. CSF study showed 2 cells with slightly elevated proteins. A magnetic resonance imaging of the brain showed bilateral symmetrical hyperintensities and swollen appearance of the thalamus on T1 weighted images. The corresponding T2 weighted images and the flare images showed hyperintensities in the thalamus, which was surrounded by a thin rim of hypointensity, which is suggestive of hemorrhagic changes. This is called the double donut sign, which is typical of ANEC. A T2 weighted image at the level of the midbrain showed involvement of the midbrain structures, the red nucleus and the substantia nigra, giving the appearance of a small panda sign. Thus, a diagnosis of ANEC secondary to dengue fever was made. The child was managed with anti-raised ICP measures, anti-seizure medications, and multimodal neuromonitoring. For ANEC, specific therapy using pulse methylprednisolone at 30 mg per kg per day intravenously for 5 days, and 3 cycles of plasmapheresis on day 2, 4, and 6 were done. The raised ICP decreased, but profound encephalopathy persisted, for which the child required tracheostomy. He was discharged on day 38 with a PCPC score of 5. The second case is a child, a 10-year-old girl, Miss P, who presented with fever for 7 days, seizures and altered sensorium for 2 days. She was also from a rural area and belonged to the lower socioeconomic class. She had an unstable airway with neurogenic breathing, a GCS score of 8/15, and had features of raised intracranial pressure. Laboratory findings showed severe thrombocytopenia, raised transaminases, and CRP. She also had a high serum interleukin 6 levels. Etiological workup was positive for dengue. CSF showed no cells, however, the proteins were elevated. An MRI brain done on day 2 of stay showed bilateral symmetrical hyperintensities in the thalamus in both the flare and the T2 weighted images. In the diffusion weighted imaging, there were bilateral bright signal intensities in the thalamic region as well as in the parieto-temporal periventricular deep white matter region, with corresponding hypointensities on the ADC imaging. These findings were also suggestive of ANEC, and the etiology was secondary to dengue fever. Neurological management was done similar to the first case. For specific therapy for ANEC, pulse methylprednisolone was given for 5 days at 30 mg per kg per day. And since the interleukin 6 levels were elevated, IL-6 blockade using tocilizumab, a single dose on day 2 at 12 mg per kg intravenously was given. This child improved dramatically and could be extubated by day 5. He was discharged on day 10 with a PCPC score of 1. ANEC is an under-recognized clinico-radiological disorder secondary to various organisms like influenza A and B, HHV6, enterovirus, dengue, SARS-CoV-2, and human metapneumovirus. There is a genetic predisposition with RANBB2 gene pathogenic variants increasing the predisposition. The main pathogenesis is an exaggerated immune response to these viral organisms, leading to a cytokine storm. The diagnostic criteria proposed by Mizuguchi et al. Includes an acute encephalopathy following a viral disease with absence of CSF pleocytosis, commonly elevated CSF proteins, and typical neuroimaging findings with lesions involving the thalami, brainstem, and the periventricular white matter that we have already seen, with elevation of transaminases to different degrees and exclusion of common resembling diseases. All these 5 criteria were fulfilled by both our cases. There are no standard guidelines for the management of ANEC. However, studies have shown that early methylprednisolone pulses, interleukin 6 blockade with tocilizumab, and plasmapheresis have resulted in better outcomes. Our first case was managed with methylprednisolone and plasmapheresis, and the second child was managed with methylprednisolone and tocilizumab. Despite such rigorous management, the prognosis of ANEC is usually fulminant, with a 30 to 40% mortality rate, and most survivors having moderate to severe neurological disability similar to a first child. Less than 10% of patients recover completely, similar to a second child. So NX should be suspected in any child with acute encephalopathy, transaminitis, and absence of CSF fluocytosis. Early neuroimaging, that is MRE, and early immunomodulation will help in improving outcomes. These are our references. Thank you.
Thank you for this interesting case, elaborate discussion. Just as a clarification, by the end of this competition, we will have a poll for you to vote for the case that you like the most. So this is how we will determine who will be the winner of the People's Choice Award. Now, moving on to Nepal, Dr. Abhikanta Katiwada will be presenting a case of an autosomal dominant osteopetrosis.
Hello, my warm greetings to the Pen Radiology Global Health Team. I'm Dr. Abhikant Katiora, resident from IMTUTS, Nepal. And I feel privileged to present this case in such a global platform. And it's about a rare case of autosomal dominant osteopetrosis with extramedullary hematopoiesis and hypersplenism. So first, starting with a brief history, a 26-year man from rural Nepal presented to our hospital with the chief complaints of progressive abdominal distension for the last 5 years and a recent history of fracture of his right leg bones. He had a past history of recurrent bone fractures since an early age. The fracture involved multiple limbs and it usually occurred with minor trauma, and each time it was managed conservatively without detailed investigations. And once at 17 years, he even had operative management for left humeral fracture in our neighborhood countries. He had delayed and malformed dentition. He had repeated blood transfusion history over the last 5 years. There was no any significant family history. On examination, he had deformed limbs, absent lower jaw teeth, pallor and icterus was present. There was no any findings suggestive for cranial nerve compressions. This per abdomen examination revealed massive splenomegaly with mild hepatomegaly, and the lab investigation showed pancytopenia with reticulocytosis, hyperbilirubinemia, and the serology showed hepatitis B positive, possibly due to the complication of blood transfusion. So this was the chest X-ray done on our emergency department, and it revealed multiple diffuse sclerotic and thickened bones with poor differentiation between the cortex and medulla. There we can see the bone within bone appearance more evident on the long bones as shown by these yellow arrows. We can see the thickened and sclerotic in plates of the vertebrae giving the sandwich appearance shown by this greenish arrow, and we can see the subtle fractures shown by this red arrow on the lateral aspect of the ribs. The next image shows the X-ray of the right leg, AP and the lateral view, which shows multiple transverse fractures involving the diphyseal region of both tibia and fibula. We can see the callus formation as evident by these red arrows, and we can see the diffuse cortical thickening with obliteration of the medulla as evident by this greenish arrow. We can see the lateral bowing of the tibia as shown by this yellow arrow, and we can see the metaphyseal flaring leading to the early Mayer flax deformity shown by this purplish arrow. So the CT scan was performed, and it showed gross splenomegaly with the tip reaching up to the right iliac fossa. We can see the mild hepatomegaly. The portal vein was enlarged, measuring up to the 26 mm. The splenic tail was dilated and tortuous as well, and the mild ascites was present. The next image shows multiple bilateral extramedullary sites of hematopoiesis at the thoracic level, and we can see the diffuse sclerotic vertebrae as well. With these clinical findings and the radiological investigation, a final diagnosis of adult autosomal dominant form of osteopetrosis with extramedullary hematopoiesis and hepatosplenomegaly was made. The pancytopenia in this case can be explained by one, the medullary encroachment leading to decreased blood cell production, and the other hypersplenism leading to the increased destruction of the blood cells. This case was managed conservatively. Splenectomy or splenic vein embolization, though planned, could not be performed due to the high morbidity of the patient. He was having constantly lower hemoglobin, and he had severe blood transfusion reaction as well. So discussions regarding this case: adult autosomal dominant osteopetrosis is a genetic disorder caused by the osteoclastic defect, and it presents with a typical history of recurrent bone fractures with normal healing. Marrow encroachment can lead to pancytopenia, extramedullary hematopoiesis, and splenomegaly. What went wrong in this case? So mere symptomatic management without proper digging into the history is one of the major drawbacks in resource-limited settings like ours. Even in well-equipped centers, this sort of disease process may be missed unless there is multidisciplinary approach. So are there other such cases? Yeah, this case highlights just the tip of the iceberg. Many such cases are left undiagnosed and many of them even don't get access to the tertiary center, lack of medical awareness and poverty being the major cause in our settings. So the take-home message from this case is proper history with high degree of clinical suspicion as well as proper radiological investigation is the key for early diagnosis, leading to the optimal management and thus improving the quality of life in these patients. These were my references. Thank you.
All of these cases are really impressive, very well discussed and presented. Now moving on to our 7th case. By the way, we have around 144 participants now live with us. Thanks for everyone who tuned in for this case competition. Now going back to the Philippines, Dr. Kazia Marie Montebon Solano will be presenting a case of a 2-month-old with lipoid pneumonia.
Good day, everyone. I am Dr. Kazaya Marie Montebon Solano, a radiology resident of Davao Doctors Hospital in the Philippines. I will report a case of a 2-month-old female presenting with lipoid pneumonia secondary to exogenous chamomile oil, or Ascieta de Manzanilla. I have no disclosures for this presentation. The patient had an otherwise unremarkable past medical and social history. However, it's important to note that since the first week of life, chamomile oil has been consistently applied to the patient's body. About 19 hours prior to admission, the patient's face and chest were soaked with chamomile oil. In the hours leading to admission, she became progressively irritable. At the emergency department, the patient was febrile and tachycardic, with a normal respiratory rate, but with episodes of desaturation. She also tested negative for SARS-CoV-2 infection. The admitting chest radiograph suggests an inflammatory lung disease, consequently diagnosed as pneumonia, with consolidation in the right upper lobe. This was managed as a case of severe pediatric community-acquired pneumonia and treated with an antibiotic regimen. During the course of admission, cardiology evaluation found concurrent infectious myocarditis, and the repeat chest radiograph revealed bilateral airspace consolidation. Worsening of clinical condition prompted transfer to the pediatric intensive care unit. Due to a history of repeated exposure to oil, high-resolution CT scan of the chest was done, which revealed bilateral pneumonia, showing areas of fat attenuation within the areas of consolidation, leading to a diagnosis of exogenous lipoid pneumonia. Corticosteroid treatment was then started. After initial corticosteroid treatment and appropriate medical management, there was improvement in the patient's clinical condition. However, serial chest radiographs showed progression of the findings of airspace consolidation. At this point, bronchoalveolar lavage was advised. Bronchoalveolar lavage was performed at a different institution for both diagnostic and therapeutic purposes. The results were suggestive of the presence of lipid-laden macrophages, which is characteristic for exogenous lipoid pneumonia. On follow-up, there was further clinical improvement with an unremarkable 2D echo and complete clearing of airspace consolidation 1 month post-lavage. 4 months following lavage, follow-up CT scan showed near complete clearing of bilateral ground glass opacities and consolidation, with a residual opacity in the medial segment of the right middle lobe. The typical HRCT findings in lipoid pneumonia are nonspecific, which include airspace consolidation, ground glass opacities, the crazy paving pattern, and mass-like lesions. Recognition of these radiologic findings, combined with a thorough clinical history and cytologic analysis, are all important factors in the diagnosis of exogenous lipoid pneumonia. These are my references. Thank you for your time.
Thank you for this very interesting case of how clinical history and combined with images can help diagnosing rare cases. So moving on to our 8th case for tonight from India, Dr. Sankit Das will be presenting a case of peripheral vascular thrombosis and cerebral hemorrhage.
Hello everyone, I am Dr. Sanket Das, Senior Resident from the Division of Neuroimaging and Interventional Neuroradiology from the Department of Radiodiagnosis and Imaging, Postgraduate Institute of Medical Education and Research from Chandigarh, India. And I will be presenting an interesting case where peripheral vascular thrombosis and cerebral hemorrhages were associated with a single disease entity. So this was a 35-year-old female who presented to our hospital with progressive pain and discoloration of toes and fingers. She was not a known diabetic or hypertensive, and she was neither was a smoker or alcoholic, and there was no family history or history of any abnormal drug intake. A Doppler ultrasound was performed which showed monophagic waveform in the distal arteries of right upper limb and bilateral lower limbs. So to further evaluate, a CT angiography of bilateral upper limbs and the lower limbs were performed. So this is the CT angiography image. This is the MIP and the VRT reconstruction of upper limb angiography, where we can see that there is a filling defect in the distal brachial artery extending to its proximal bifurcation. And this is the angiography of the abdomen and the bilateral lower limbs, where we can see this filling defect in the distal part of the abdominal aorta extending to bilateral common iliac arteries. So to evaluate the cause for this thromboembolic phenomena, further workup was done. The hematological workup came out to be normal. However, the 2D echocardiogram of the heart showed a 5 into 6 centimeter sized hyperechoic mass in the left atrium, likely suggestive of an atrial myxoma. So to prevent the thromboembolic complications, anticoagulation therapy was started in the patient and a surgery for the cardiac myxoma was scheduled. Now, 2 weeks later, the patient presented with severe headache for which MRI brain was performed, and the MRI, this is the susceptibility weighted imaging of the brain, which shows multiple innumerable number of microhemorrhages diffusely scattered in bilateral cerebral hemispheres. So these hemorrhages were thought to be the complication of the anticoagulation therapy, and therefore the anticoagulation was decided to be stopped in this patient. However, the headache persisted, and few days later, the patient presented with a drowsy and unconscious state into our emergency. And the emergency CT had showed the presence of a large hematoma in the right temporal region with associated mass effect. And this is the CT angiography image, which shows multiple number of aneurysms arising from the distal cortical branches of bilateral ACA and MCA, and there is a large 10 into 8 mm sized aneurysm arising from the distal cortical branch of right MCA, seen in relation to the hematoma in the right temporal region. So this was thought to be a ruptured aneurysm in this case. And now an emergency evacuation of the hematoma as well as excision of this aneurysm was performed. And this is the postoperative CT head and the CT angiogram that shows postoperative changes and the encephalomyelitic changes in the right temporal region. And the culprit aneurysm is now excluded from the circulation. However, the other aneurysms that were seen previously are still persisting. Now, 2 months later, the cardiac mass was excised and the histopathology of the mass was confirmatory of cardiac myxoma. So this is a 1-year follow-up MRI with MR angiogram that shows this persistence of microhemorrhages in the brain. However, no evidence of any new microhemorrhage is seen as compared to the previous MRI. And this is the time of flight MR angiogram. This is the axial and the coronal MIP reconstruction, where we can see significantly reduced number of aneurysms as were seen in the previous preoperative MRI that was done 1 year previous. Now, few of the aneurysms are still remaining. However, they are also significantly reduced in size as compared to the previous scan. So, cardiac myxoma is associated with thromboembolic complications, which may result in peripheral vascular ischemia as well as ischemic complications of central nervous system. An unusual presentation in this disease is cerebral aneurysms, especially involving the distal cortical branches of ACA and MCA. These are mainly thought to be the result of proliferation of the myxoma cells in the arterial walls, resulting in both narrowing as well as dilatation, and can present in both ischemic as well as hemorrhagic complications. Interestingly, both of them are reduced significantly after the treatment of the initial primary disease. The aneurysms are usually reduced in size or may even disappear following the surgical removal of the myxoma, as was reported in our case. So these are the references, and thank you very much.
As I said, all of the cases are interesting and very challenging. And now to a new case from Indonesia. Dr. Fergie Bontoro will be presenting a case of Salmonella meningitis, an atypical presentation. Let's see how they dealt with it.
Good day, everyone. Thank you for your time to be here. Before we start, let me introduce myself. My name is Fergie Buntoro from Medical Faculty Pelita Harapan University, Indonesia. I, with my mentor, Ratna Sutanto and Amelia Putri, Radiology Department, Siloam Hospital, Indonesia. Today, I would like to do my case presentation about Salmonella meningitis, an atypical manifestation of Salmonella species in young child, a case report from Indonesia. Salmonella meningitis, an uncommon and severe manifestation of bacterial meningitis, is attributed to a gram-negative bacillus belonging to Enterobacteriaceae family. The condition primarily impacts the newborns, children, and individuals with impaired immune systems, relatively common in developing countries. Salmonella meningitis has notable fatality rates, substantial neurological impairment, and a worse prognosis than other bacterial meningitis. Imaging has a role in cases with neurological deficits. Contrast-enhanced brain MRI and CT help to evaluate abnormal finding intracranial. Our case is a female, 1-year-old, presented to the emergency department with chief complaint of loss of consciousness and seizures. The patient was born prematurely at 34 months of gestation by cesarean section with her twin. No history of typhoid vaccination. The child had a history of being treated in another hospital 7 weeks earlier with a diagnosis of meningitis, normal brain CT scan findings, and Salmonella found in CSF analysis. 2 days before the latest hospital admission, she had PCV and influenza vaccination and had mild fever after the shot, which became a high fever on the second day that did not improve with antipyretic medication. The patient also got seizure in her right hand and worsening to general seizure with loss of consciousness and doesn't improve with anticonvulsive medication. Lab finding, anemia, hyponatremia, high CRP, CF analysis non-negative, PANDI positive, cell count 40 per microliter. She was treated with meropenem 200 to 400 mg given intravenously at 8-hourly interval for 10 days, after which a contrast-enhanced brain MRI follow-up was performed. A brain CT scan showed increased density in the subarachnoid, left frontoparietal region on axial non-contrast and coronal non-contrast, with enhancement in the corticomeningeal left frontoparietal tube on axial contrast and coronal contrast. Contrast-enhanced brain MRI showing leptomeningeal enhancement in the left frontoparietal region and dura mater on the left frontal region in T1, T2, and flare, with restricted diffusion in diffusion-weighted imaging and apparent diffusion coefficient. The host inflammatory response and immune system activation contribute to the effect of bacteria invading the meninges and persisting in the subarachnoid space. Neuroimaging is advised for all patients with Salmonella meningitis, even if the clinical course is good, due to the possibility of recurrence. A brain CT may be negative, show effacement of Samstucci and leptomania enhancement, and excludes a mass lesion or other sign of elevated intracranial pressure. Meningeal enhancement is seen on contrast-enhanced MRI, which makes it helpful in suspected situation. In this patient, there is left frontoparietal meningitis on contrast-enhanced brain CT and MRI. If left untreated, Complication could include brain abscess, ventriculitis, and hydrocephalus. This case report aimed to highlight the importance of rare manifestation of Salmonella, especially because the prevalence of Salmonella infection is increasing in developing countries. Patients with Salmonella meningitis require monitoring for acute complication as well as long-term of neurological sequelae. Since Salmonella infection have propensity to relapse, it is crucial to ensure that patients are monitored frequently until they have fully recovered. Thank you once again for your time and attention.
Thank you, Dr. Fergie, for sharing this case of a typical presentation of Salmonella. Now moving on to the Philippines, and this would be our 10th case for tonight. After this case, we will move on to a brief intermission of 10 minutes as a small break. But before we do, Dr. Iris Joanna Isip will be presenting a case of evaluating disease activity in Takayasu arteritis.
Good day, everyone. I am Iris Isip from St. Luke's Medical Center, Quezon City, Philippines. The following case report will delve into the role of PET-CT and CT in the management of Takayasu arteritis in a tertiary referral institution in the Philippines. I have no conflicts of interest to declare. A 29-year-old Filipina sought private consultation due to a 1-year history of weight loss, intermittent abdominal pain, syncopal episodes, and palpitations. Physical examination revealed left carotid bruit and blood pressure difference in all extremities. Diagnostic workup was done showing aneurysm of the ascending aorta on 2D echocardiogram, elevated serum ESR and CRP, and multiple stenotic lesions on carotid and vertebral artery duplex scan. A CT angiography of the whole aorta was done, showing multifocal areas of fusiform dilatation of the thoracic aorta, as shown by the black and white arrows. There is also wall thickening in the ascending arc, descending abdominal aorta, innominate artery, both common carotid and subclavian arteries. Ectasia is likewise noted at the level of the renal artery takeoff, as shown by the yellow arrow. The patient was diagnosed with Takayasu arteritis, fulfilling 1 major and 4 minor of the modified Ishikawa criteria. She was then started on high-dose methotrexate therapy. A baseline PET-CT scan was done 6 months after therapy, showing diffuse mild hypermetabolism in the walls of the ascending aorta, aortic arc, as well as hypermetabolism in the vertebral arteries, encircled in white, with no hypermetabolic evidence of active inflammatory vascular disease in the abdomen. These were accompanied by normal ESR and CRP levels. Methotrexate dose was then increased. Serial monitoring was done with CT angiography showing relatively stable wall thickening and fusiform dilatation of the aorta and its branches. On the other hand, serial PET-CT scan showed metabolic progression in the vertebral arteries encircled in white, descending aorta, brachiocephalic, both common carotid and subclavian arteries, pointed by the green arrows, as well as in the wall of the proximal descending aorta, shown by the white arrow, and proximal descending aorta, shown by the black arrow, despite continued titration of methotrexate therapy. Patient was then diagnosed with refractory Takayasu arteritis and started on tocilizumab. Takayasu arteritis is a rare form of progressive autoimmune large vessel disease, initially presenting with nonspecific signs and symptoms. Early diagnosis and monitoring remain the mainstay of management to prevent life-threatening complications. Clinicians use different diagnostic criteria in the diagnosis and evaluating its activity, which involves clinical features, imaging, and inflammatory biomarkers. CT angiography findings include stenosis, occlusions, aneurysms, and thickening of arterial walls. Certain medications used in the management of arteritis, however, can halt production of inflammatory biomarkers and resolve nonspecific symptoms, adding to the complexity of monitoring disease and activity and treatment outcome. Multiple studies are now evaluating the utilization of FDG PET-CT in the assessment of large vessel vasculitis. Unlike other imaging techniques, it provides a comprehensive assessment of inflammatory lesions in the arterial wall even before the visualization of structural damage, as well as evaluation of disease activity during and after immunosuppressive therapy. A study by Han et al. Suggests that diagnosis of Takayasu arteritis based on clinical and laboratory markers can lead to bias, while angiography alone is inadequate in the assessment of structural damage and recommends the routine use of F18 FDG PET-CT imaging to improve patient outcomes. This case report highlights the significance of functional imaging with FDG PET-CT, enabling the early and comprehensive assessment of disease activity and extent. These are my references. Thank you.
Thank you for this case about Takayasu arteritis. We received a lot of cases about Takayasu this competition, which was kind of expected. But anyways, moving on. Now we will be having a 10-minute intermission. Thank you for the 170 live audience now watching this this competition. I leave you now to some Asian music. I hope you can enjoy, and then we will be back after around 10 minutes. Hey, welcome back, everyone. We're gonna start sharing once again. Okay, so I'm gonna hand it now to Dr. Monica. Dr. Monica is gonna host the show from now on. Okay, let's hear it from Dr. Monica.
Hello, everyone. The first half of the case competition was really exciting. We can't wait for this second half. Stay tuned until the end because we will have the voting for the People's Choice Award. So the second session is going to start with Dr. Hanina P. from Malabar Medical College in Kerala, India. She's going to present on ovarian cyst with bony lesions.
Hello everyone, I'm Dr. Hanina, currently pursuing my MD in radiodiagnosis from Malabar Medical College, Calicut, India. I would like to thank my mentors, Dr. Nawab, and my head of department, Dr. Gomadi. My topic is Unlocking the Puzzle, ovarian cyst with bony lesions, not always metastasis. I would like to present the case of a 18-year-old girl who presented with abdominal distension. She had past history of ovarian cyst, for which ovarian cystectomy was done 5 years back, and histopathology report came out to be follicular cyst. And now she came with recurrent ovarian cyst. For the further evaluation of the cyst, USC abdomen was advised by her gynecologist, in which the right ovary showed a large, well-defined, thin-walled anechoic cystic lesion, which was measuring about 4 cm with posterior acoustic enhancement. No septation, calcification, fat density area or solid component was seen, and it was a ORATS US category 3 lesion, and in left ovary a small ORATS 1 lesion of approximately 1 cm was noted. So for further evaluation and characterization of the lesion, MRI abdomen and pelvis was advised. T2 weighted sagittal section was showing a well-defined, large, smooth-walled right adnexal cystic lesion, which was noted extending up to the epigastrium superiorly, and anteriorly it was extending up to the anterior abdominal wall, and it was displacing the bowel loops laterally, and it was extending up to the posterior paravertebral, up to the paravertebral space posteriorly, and no evidence of ascites was seen. In T1 weighted images, the cyst was showing hypointensity, and in post-contrast images, it showed mild, smooth enhancement of the wall without any enhancing septation or solid component. Diffusion weighted image showed no evidence of diffusion restriction of the ovarian lesion, but multiple bony lesion with diffusion restriction was seen. So a benign ovarian lesion in a young woman with bony metastasis-like appearance is noted. So is it possible for an ovarian lesion to exhibit metastasis in a young girl with a benign looking cyst? So are we potentially overlooking a crucial piece of puzzle? So we took a CT correlation for this patient. It showed a well-defined large cystic lesion in the right adnexa without any evidence of calcification, septation, solid component, or papillary excrescences. And it also showed multiple expansile lytic lesion with cortical destruction and ground glass matrix in the pelvic bone. So since there is ground glass matrix, could this be a fibrous dysplasia? So are we considering a potential of multiple lesion? So to rule out multiple lesion, skull X-ray and pelvic X-ray was taken. So the skull and pelvic X-ray showed multiple lytic expansile lesion with ground glass matrix was noted. So this was a polyostotic fibrous dysplasia. So we again went back to the patient, and further inquiry into the patient's history revealed a history of vaginal bleeding at the age of 3 years. And upon examination, capillary spot were also observed. So this was a case of McCune-Albright syndrome. On history, there was history of precocious puberty, and on examination, capillary spot was noted on skin, and by using CT and X-ray, pelvis and skull, it showed polyostotic fibrous dysplasia, and there was features of hyperestrogenism in the form of recurrent ovarian cyst. So this patient was surgically managed with excision of the ovarian cyst, and patient was medically managed with estrogen receptor antagonist for recurrent ovarian cyst, and bisphosphonate was given for this patient for bone stabilization. McCune-Albright syndrome is considered to be a sporadic disease characterized by triad of polyostotic fibrous dysplasia, precocious puberty, capillary spot. When at least two are present, the diagnosis is confirmed, and other endocrine manifestations like gonadal hyperfunction of the thyroid and adrenal cortex, as well as excessive growth hormone secretions are also seen. The usual presentation is precocious puberty, but this was a case of 18-year-old girl who had a delayed presentation of McCune-Albright as recurrent ovarian cyst. So in conclusion, not all bony lesions with ovarian cyst indicate metastasis. So history, clinical examination, and exploring differentials like this can alter treatment strategy for the patient, and also it will improve the outcome.
This was a great case, very comprehensive, with wonderful images. Thank you. Now we're going to go to Vietnam. We have Dr. Le Tran Kham Nam from Binh University presenting lung cancer resembling pneumonia.
Hello everyone, my name is Lê Trần Khánh Lâm. I'm the fourth year medical student studying at the university, which is located in Hanoi, Vietnam. And it's my pleasure to have my mentor as Dr. Phạm Văn Luận, who is working at the Department of Respiratory Medicine in 108 Military Central Hospital in Hanoi, Vietnam. So today I would like to present a case titled Lung Cancer, which features resembling pneumonia on chest CT. So now I would like to give you a brief description of the case. A previously healthy 42-year-old male presented at the hospital with the symptoms of dyspnea and productive cough with the amount of 500 milliliters sputum per day. So initially, he was diagnosed with pneumonia but did not respond well to the treatment. So after 5 months, the patient received a new diagnosis of lipidic predominant adenocarcinoma in the left lower lobe metastasizing to the right lung. And his biopsy result showed that the PD-L1 TPS lower than 1% and also positive KRAS G12V mutation and negative EGFR and ALK mutation. So the treatment consisted of pemetrexed, carboplatin combined with pembrolizumab 6 cycles, by which the patient responded well, and followed by the pemetrexed alone for 2 cycles, since he could not afford the pembrolizumab. However, the disease progressed, and the patient subsequently received docetaxel for 5 cycles. So during the current hospital presentation, the patient reported coughing up the frothy sputum 400 milliliters per day and experienced the exertional dyspnea. So the physical examination is significant for the performance status score of 1, and no peripheral lymphadenopathy, decrease in the breath cells in the left lung, and crackles in both lungs. So the patient denied chest pain, anorexia, and any abnormalities in urination or and bowel movements. So now move on to the next part, which is the unique past medical and social history. So what is special about this patient is that the patient presents with the productive cough, dyspnea, and also the findings of consolidation localized in the cingulate on chest CT, which is typical indicator for the pneumonia. So therefore, the patient came to several hospitals and still had the same diagnosis with the pneumonia, but he did not respond well to the treatment. So subsequently, the patient was diagnosed with the lung cancer, which also typically present with solitary nodule rather than consolidation. So now, moving on to the most important part of the case, which is imaging. So first of all, you can see the apical chest X-ray, which show the consolidation marked in the red circle in the left lower lobe with many round and bright black nests look like keys behind of the heart. So next one is also the consolidation in the left lower lobe, but also we have the cavitatory necrosis marked in the red arrow in the left lower lobe, and also we can see the scatter bronchial dilation bilaterally. Okay, so the next one, here we can see the metastasizing nodules in the right lung. Okay, so now we come to the take-home points. So pneumonic type lung adenocarcinoma can be misdiagnosed with infectious pneumonia due to the similar presentation, and these two often have the early symptoms that is the same as its other, which is cough, sputum production, and dyspnea, and also the lack of specific symptoms. In typical cases, the patient's sputums are often foamy, and imaging findings such as ground glass opacity or lung consolidation resembles those seen in pneumonia. So clinicians must remember this type of lung cancer, particularly when you meet the patient with clinical and radiological signs indicative of unresolved pneumonia resistant to the antimicrobial treatment. So this is my reference, and thanks for your attention.
Thank you for this very detailed case. Now we're going to Nepal, where Dr. Alok Kumar Yadav from Tribhuvan University Teaching Hospital in Nepal will present female genital tract tuberculosis.
Hello everyone, this is me Alok Kumar Yadav from Nepal, and today I am very happy to share one interesting case where there was diagnostic dilemma in the diagnosis of female genital tract tuberculosis, and I would like to thank Dr. Anamika Jha and Professor Dr. Benulohani from my department for guiding me for making of this presentation. So coming to the case, she was 40 years lady who presented with the chief complaint of the secondary amenorrhea for the 5 years, and she also has abdominal pain, vaginal bleeding, as well as a whitish discharge for the 6 months, and there is no any significant past and family history. For abdominal examination was soft with mild tenderness in the pelvis, and chest examination was within the normal limit, and poor speculum examination shows the presence of edema cervix. A significant lab finding in this patient was raised ESR, chest X-ray was normal, and pelvic USC shows the thickened endometrium. So in the view of thickened endometrium and the poor vaginal bleeding, patient was advised for the MRI for the further evaluation. This is the MRI of the same patient. This one is titulated image, surgical image of the patient, where we can see that there is diffuse thickening of the endometrium, as well as the endometrium is slightly hyperintense compared to this normal myometrium. Along with that, there is diffuse thickening of endocervix also, and there is presence of some free fluid within the abdomen suggestive of the ascites. Also, there was presence of one subservical fibroid in this patient. And on the T1 meter contrast image, we can see that this one is the endometrium, and the endometrium is showing slightly hyper-enhancement compared to this normal myometrium. And on the DWI weighted images, the thicker endometrium is bright in the color, and on ADC map, it appears black in the color, suggestive of the diffusion restriction. And on T2 weighted coronal image, we can see the omentum and magenta slightly appear hazy in the color. However, there is no any finding of the perihepatic fluid collection, or there is no any necrotic lymph node within the mesenteric. So with the MRI finding of the thickened endometrium, which is irregular in the outline, and along with that the presence of the hypoenhancement and the diffusion restriction, these all findings are suggestive of the endometrial carcinoma, and provisional diagnosis of endometrial carcinoma was made. And patient was planned for the biopsy, and endometrial biopsy was done, which shows the presence of the multinucleated giant cells within the endometrium. This is the multinucleated giant cells, and along with that there is chronic inflammatory cells in the background, which these findings are suggestive of the chronic granulomatous inflammation, and these are in the favor of the infective pathology, likely tuberculosis in this case. With this background, the antitubercle therapy was started, and patient is now improving with decreased abdominal pain, and there is no any PV bleeding with the therapy of antitubercular treatment. So take home point from this case is that TB is a great mimicker of gynecological malignancy, and as both TB and malignancy can present with a vaginal bleeding as well as abdominal pain. And although endometrial carcinoma is more common in postmenopausal age group, it can present in premenopausal age group also in 40 to 20% of cases. But whenever there is confusion, the finding in the favor of TB are presence of hydrosalpinx, pyosalpinx, tuboovarian abscess, peritoneal nodularity, omental caking, perihepatitis, and mesenteric necrotic lymph nodes. But all these findings were absent in this case, so the provisional diagnosis was endometrial carcinoma was made. But the take home point is that whenever there is thickened endometrium and there is presence of ascites, so especially without the myometrial invasion, we should suspect endometrial tuberculosis, especially if the patient belongs to the TB endemic zone. Thank you. I hope you guys enjoy that. This is interesting case.
Thank you for that really interesting case. The competition is getting really tight, so stay tuned because cases are getting really interesting as time goes by. So now we're going to go back to Indonesia. From Pelita Harapan University, we have Dr. Jessica Cristanti presenting complicating appendicitis with intestinal malrotation.
Good day, my name is Jessica Cristanti from Radiology Department Medical Faculty of Pelita Harapan University Indonesia. And with my mentor Mira Yuniarti, Radiology Department Siloam Hospital Denpasar, Indonesia. It is a great pleasure that I present to you a medical case report entitled Diagnostic Delay of Left-Sided Complicated Appendicitis with the DeAngier-CL Subtypes of Intestine Malrotation in Computed Tomography CT Classification Case Report. Complicated appendicitis is a severe acute condition that primarily affects the lower right abdomen that can lead to severe complications such as peritonitis, abscess, and even death. Bowel malrotation is a rare congenital disorder that occurs in estimated 1 in 6,000 live births. Intestinal malrotation completes 10 subtests based on CT, including the DeAngier-CL, which is the focus of this presentation. We will present a case study of delayed diagnosis of left complicated appendicitis with intestinal malrotation type DeAngier-CL. This slide presents a schematic diagram of 10 subdepth in the intestinal rotation, with our case being the DNGRCL, meaning non-rotation duodenal, right jejunum, and left cecum. Our patient was 21-year-old male who presented with recurrent lower left abdominal pain and constipation that persisted for a month. Despite initial treatment with painkillers and laxative, the pain intensified, accompanied by vomiting and severe constipation. Physical examination revealed tenderness from the left lower abdomen, and the laboratory result indicated leukocytosis, elevated neutrophils, and high neutrophil lymphocyte ratio, indicating an inflammatory process. The emergency physician initially diagnosed constipation with a differential diagnosis of ileus before ordering a non-contrast abdominal CT. The patient underwent non-contrast abdominal CT with the result as follows. We can see the non-contrast abdominal CT result with axial view. We can see a hyperdense lesion with 221 Hounsfield unit, probably appendicolite, seen inside tubular structure in the red arrow. And a coronal view showed a tubular dilated blind-ended structure in right arrowhead connected with the cecum in yellow arrowhead at the left lower abdomen quadrant with a significant fat standing adjacent to it. Another coronal view showed ileum in the right abdomen, showed in blue arrowhead, and cecum in left mid-abdomen, and hyperdense lesion probably appendicolite. Thus, our clinician diagnosed intestinal malrotation with left-sided acute appendicitis. The patient underwent appendectomy. The appendectomy procedure showed periappendicular abscess in this patient, which revealed suppurative Black Mounds acute appendicitis with periappendicular infiltrate based on histopathologic examination. Patient was hospital for 3 days and then discharged as an outpatient. The clinician overlooked acute appendicitis on the left side due to their initial differential diagnosis of colonic and renal pathology, and also bias toward constipation. The American College Radiology Appropriateness criteria can be proposed for contrast or non-contrast abdominal CT scan or abdominal ultrasound to diagnose unexplained abdominal pain. Surgical intervention in form of appendectomy was crucial in this case to prevent the progression of infection in peritonitis. Based on our cases in Indonesian condition, the Ministry of Health aims to make ultrasound available in primary health care and provide training for general practitioners by 2024. Currently, the focus of antenatal care and basic training, but the Ministry of Health plans to offer abdominal ultrasound training by the radiologists. With the availability of ultrasound in primary health care and doctors' knowledge of anatomical variation, diagnosis accuracy will improve and delays in diagnosing acute abdomen will be reduced. These are references. Thank you for your kind attention.
These are all great cases with incredible images. You can tell that people put a lot of time into these cases, so thank you so much. Coming up next, we have another case from the Philippines. From University of the Philippines, Manila, Philippine General Hospital, we have Dr. Christopher Peralta presenting childhood onset Takayasu arteritis. Let's see this case of Takayasu, how it's presented.
Good day, everyone. I am Christopher T. Pilarta, a second-year radiology resident from the University of the Philippines, Manila, Philippine General Hospital. I have no conflicts of interest to disclose. Together with my advisor, Dr. Romelito Jose G. Galsim, let me present to you a case report entitled Twists and Turns, a case of childhood-onset Takayasu arteritis. Takayasu arteritis is a chronic inflammatory disease which affects large vessels, predominantly the aorta and its major branches. It usually occurs in patients younger than 50 years of age, females, and those of Asian descent. Worldwide, the incidence is estimated at 2.6 cases per million per year, and among these cases, 1 out of 5 represent childhood-onset disease. There has been growing evidence that Takayasu arteritis is associated with tuberculosis infection. However, direct evidence linking these two conditions remains uncertain. This is a case of a 9-year-old Filipino female who initially presented with sudden onset generalized seizures. She received the BCG vaccine previously and she had no exposure to a confirmed TB case. She was seen at the emergency department febrile and with altered consciousness. All her peripheral pulses were palpable. There were no murmurs or abdominal bruits. Her blood pressure was elevated for age. Laboratory results revealed elevated inflammatory markers, elevated plasma renin and aldosterone levels, and a positive TB quantiferon result. Now, allow me to discuss the different imaging findings for our patient. In our case, an abdominal CT angiogram was performed to investigate for a possible cause of renovascular hypertension. Here we demonstrate severe stenosis of the proximal segment of the right renal artery, which is the primary cause for the patient's uncontrolled hypertension. This is further supported by renal Doppler findings showing decreased resistive index and tardus parvus waveform. Additionally, there is diffuse long segment thickening of the intima media of the abdominal aorta with fusiform dilatation from the level of the celiac up to the superior mesenteric trunk. We also noted saccular and fusiform aneurysms along the superior mesenteric artery pointed by the green arrows and an area of stenosis pointed by the blue arrow. While hypertension is usually the presenting feature of Takayasu arteritis, some cases can present acutely with hypertensive encephalopathy and lead to posterior reversible encephalopathy syndrome. In our patient, an MRI was performed to confirm this diagnosis. Here we can see symmetric T2 and flare hyperintense signals in the parietal and occipital lobes bilaterally. Incidentally, the patient's chest radiograph also demonstrates a calcified mediastinal lymph node in the left, which is likely a sequela of TB infection. It has been postulated that either latent or active Mycobacterium tuberculosis infection is a possible trigger for Takayasu arteritis. In fact, 20% of patients have previous or active TB infection, with the lungs as the most frequently associated site of infection. Furthermore, both diseases share a similar pathophysiology of granulomatous inflammation with Langerhans giant cells, with some studies showing potential cross-reaction between MTB and human heat shock protein. Others also propose that TB may be the triggering factor due to the production of superantigens. And lastly, both diseases have a shared geographic distribution. For our patient's outcome, after the diagnosis of Takayasu arteritis was made, the patient was started on corticosteroid therapy and TB treatment regimen. She was discharged well with good BP control, but still on oral antihypertensive medication. She is on regular follow-up in the outpatient department, and she is scheduled for repeat imaging after completing treatment. In summary, we highlighted the association between TB and Takayasu arteritis. But more importantly, we discussed how we arrived with a diagnosis of childhood-onset Takayasu arteritis in a patient presenting with hypertension and seizures, employing different imaging techniques to arrive first at an early diagnosis, second to evaluate for complications and associated findings, and for future monitoring of treatment outcomes. Here are my references. Thank you all for listening.
Thank you again for this wonderful case. So remember, we have 5 cases to go. Once these 5 remaining cases are presented, we will give everyone a chance to vote on a poll. This vote is going to be for People's Choice Award. So each of you that are attending this webinar will have the chance to vote for your favorite presentation. And after that presentation, we will share the results that the judges have come up with, of which are the first 3 best cases. So we will continue with our next case. Coming up next, we have from Aga Khan University Hospital in Pakistan, Dr. Abdur Rahman is going to present biotinidase deficiency mimicking neuromyelitis optica.
Hello everyone, my name is Dr. Abdur Rahman.
My case for today is a case of pyrethroids deficiency mimicking neuromyelitis optica spectrum disorder. Very interestingly, given the context of all that glitters is not gold. I'm an A2 resident at the Department of Radiology, Aga Khan University, based in the city of Karachi, Pakistan. My supervising faculty are Dr. Kiran Hilal, who's a pediatric radiologist, and Dr. Khairunisa Mukhtar, who's a pediatric neuroradiologist. My team member is Dr. Fatma Wazir, who's an A4 resident at our department. So moving on to our case and the brief history for the case. The patient was a 3-year and 6-month-old child who presented with complaints of intermittent fever along with regression of milestones and some acute complaints of cough, abdominal distension, and constipation. And interestingly enough, that the patient had a history of multiple admissions outside as suspected tuberculous meningitis versus spinal tuberculosis. On arrival, the patient was generally stable, afebrile with GCS of 10/15, and the patient was a dull-looking child. The CNS examination revealed hypotonia, congenital ptosis, but the patient was moving all 4 limbs, and other examinations such as CVS and chest were unremarkable. So the initial laboratory workup such as complete blood count and blood cultures, as well as lumbar puncture on the advice of neurology team, meningitis panel, AFP smears all turned out to be really unremarkable. And the metabolic team then advised an MRI brain and spine for the workup, of which the images of which we'll be discussing on the next slide. And so these are basically FLAIR images, sagittal and axial sections, and in which we can see that the areas of abnormal signal intensity in the sagittal image noted here in the prechiasmatic part of the optic nerve, as well as in the anterior fornix right here, and in the optic chiasma as well. We also see this abnormal signal intensity in the periaqueductal region of the midbrain. On the sagittal image of the spine, we see this long segment abnormal signal intensity area that is seen extending throughout the entire length of the cervical cords. And on subsequent post-contrast images, we see that there is patchy heterogeneous enhancement of the cervical spinal cord, and in bilateral optic nerves, especially in the precanalicular and the prechiasmatic part, there is abnormal enhancement, and the same is seen on basically coronal images as well. So based on these findings, we raised a suspicion for neuromyelitis optica spectrum disorder and advised laboratory workup for the same. But as it turned out to be, the NMO workup was negative, and methylprednisolone did not also show any improvement in the patient's symptoms. The metabolic team did have a suspicion of an enzyme deficiency simultaneously, and they had sent a urine for organic acid, and that reported biotin responsive multiple carboxylase deficiency, which was later also confirmed on genetic testing that the patient had pyrethroids deficiency with a homozygous mutation in the BTD gene. Subsequently, then the biotin therapy was started, the patient responded well clinically, and the patient was discharged. Moving on to the companion cases for the same presentation. So this is a case of a 4-year-old boy with ataxic gait, bilateral vision loss, and respiratory distress, in which we can see that there are abnormal areas of signal intensity that is seen extending throughout the spinal cord as well here. There is abnormal signal intensity area in the optic nerve with minimal post-contrast enhancement, but essentially in this case, there were areas of bilateral abnormalities symmetric in the temporal lobes. So based on the involvement of the spinal cord and the optic nerve, we call this as NMOSD as well, an advised workup, but this also turned out to be eventually a case of genetically proven pyrethroids deficiency. And finally, we have a similar case of a 6-year-old girl who presented with transverse myelitis, was being treated with steroids. And again, we see similar findings on these sections. We see this abnormal area of signal intensity, particularly in the dorsal midbrain, with abnormal area of signal intensity in the cervical spinal cord. And that really propelled us to give NMOSD as the diagnosis, as a possible diagnosis. But this case was also a genetically proven case of pyrethroids deficiency. And these cases essentially bring us to a discussion of pyrethroids deficiency versus NMOSD. Both of these diseases present very similar clinically. Both of these diseases will present similar on imaging findings as well. And so essentially it's a challenge to differentiate both of them, as both of them have different treatment regimens. If pyrethroids deficiency is not detected early, it can result in life-threatening ocular paralysis as well. On doing a literature search, we found very interesting articles related to biotinidase deficiency and NMOSD, as well as demyelinated disorders. And this helped us in retrospect really to analyze the mimicking findings between our cases. And these were a very interesting read to compare biotinidase deficiency and NMOSD. So finally, concluding my presentation with the takeaways, that there's always a misdiagnosis risk between NMOSD and biotinidase deficiency, and you always have to consider biotinidase deficiency in a patient with seronegative neuromyelitis optica spectrum disorder. In a pediatric patient particularly, you have to think about recurrent optic neuritis and myelitis and consider biotinidase deficiency as a diagnosis. Early identification is crucial because it can prevent life-threatening paralysis. With that, I end my presentation and present to you the references and a quote by Ralph Nader that your best teacher is your last mistake. As we learned through these cases. Hope it was an interesting presentation for you all. Thank you very much.
We have certainly learned a lot from these cases today. We will continue now with India. From Bharati Vidyapith Medical College in Pune, we have Dr. Shriya Srivastava. She will present unusual burning entities of seizures.
Hello everyone, this is Dr. Shreya Srivastava from Bharati Hospital, Pune, India, and I'll be enlightening you all about unusual burning entities of seizures, that is flames, fires, and SSV. Before starting my topic, I would like to thank my HOD, Dr. Prisla Joshi ma'am, and all my professors for their constant support and guidance. So the main objective of this discussion is to understand the imaging appearance of flames, fires, and SSV. So I'll be starting my case with the first. She was a 6-year-old girl brought in post-ictal state to emergency with one episode of seizure in the form of generalized tonic-clonic movements. And there was also a history of 2-3 episodes of jerky movements one day back as well. CSF examination was done and it was normal. Rest all investigations were normal. On FLAIR imaging, we found there was focal edema involving the right frontal cortex, which was appearing hyper intense on FLAIR images, and minimal leptomeningeal enhancement can be appreciated on post-contrast FLAIR images in the right frontal region only. After 1 month, she came back with the complaints of diminished vision of left eye, and we can appreciate here on T2 weighted FATSAT images, there is hyperintense signal on axial and core images, and on T1 weighted images, post-contrast images, there was enhancement, and she was diagnosed with optic neuritis. And following which we ran a cell-based assay test, which was found to be anti-MOG antibody seropositive, which was indicative of flames, that is FLAIR hyperintense lesions in anti-MOG associated encephalitis with seizures. Well, it's a very new radiological subentity of MOGAD, which is also a very recently recognized subset of CNS inflammatory demyelinating disease. Clinically, it presents as seizures along with headache, fever, and cortical symptoms, as usually in the flames location clinically. And most commonly, it is associated with optic neuritis, followed by acute disseminated encephalomyelitis and transverse myelitis. Then next case is of 2-year-old girl presented with refractory status epilepticus along with high-grade fever, cough, and hematuria. On evaluation, she was diagnosed as a case of fires with coti and ventilator-associated pneumonia. On MRI images, we can appreciate FLAIR hyperintensities in bilateral cluster region in right occipital lobe, and on ASL images, there was hypoperfusion in the temporo-occipital lobe. Follow-up scan after 2 months was indicated of brain atrophy in the form of prominent ventricles, we can see here, and prominent cortical and sulci. She was ultimately diagnosed as a case of febrile infection-related epilepsy syndrome, which is a very severe, rare severe epileptical syndrome occurring in previously healthy children and characterized by refractory status epilepticus. So there are different changes in acute phase and chronic phase. In acute, their scans could be normal, or there can be changes in temporal lobes. On chronic phases, usually there are atrophic changes and mesotemporal sclerosis. Then my last case is of a 5-year-old girl brought with complaints of myoclonic jerks with neuroaggressions, is 1.5 months. Child was unable to walk and sit. Mother gave history of febrile rashes over the body 2 years back, which subsided within 2 to 3 days. On FLAIR images, there were the multiple discrete hyperintensities in the frontal lobes. Here we can see in insular cortices and in medial and temporal lobes. So SSP is also a very rare progressive inflammatory neurodegenerative disease caused by immune-resistant measles virus following an asymptomatic period of 6 to 8 years. Clinical features can vary from behavioral changes to tonic-clonic jerks, and they initially involve the head followed by trunks and limbs. And the major imaging finding is T2-weighted multiple discrete hyperintensities in periventricular and subcortical white matter. So this is my take-home message. Flames, please, if the patient is accompanying with optic neuritis, with seizures and T2 flare hyperintensities, do think of flare. Fires, typical features of fires with a claustrum sign, diagnosis can be fires, and SSP, history of measles infection and neuroregression, along with hyperintensity on flare images, then yeah, SSP can be a possibility. So these are the typical history and characteristic MRI findings are complementary in diagnosing these conditions, aiding in early initiation of appropriate therapy, thereby potentially improving the long-term outcome. So this was an overview about all these diseases. I hope that was insightful, and thank you and have a nice day. Thank you.
Thank you so much. These cases are really interesting and we are learning a lot. Images have been very impressive as well. We have another case from the Philippines, from Eastern Visayas Medical Center. We have Dr. Gia Marie Nicolasora presenting intrathoracic renal ectopia with congenital diaphragmatic hernia.
Good day, doctors. My name is Gia Marie P. Nicolasora, a third-year radiology resident at Eastern Visayas Medical Center in Tacloban City, Philippines. I would also like to acknowledge my mentor, Dr. Patricia Dyer Mabansag. Today, I'm going to present a case of intrathoracic renal ectopia with congenital diaphragmatic hernia, a rare coexistence. This is a case of a full-term male infant who presented with respiratory distress. Upon birth at a different center, the patient manifested with cyanotic episodes, particularly during crying. The persistence of cyanosis prompted a referral to our institution, hence subsequent admission. Laboratory investigations were done and revealed Staphylococcus hemolyticus on blood culture, and the patient was managed as a case of sepsis. The initial babygram radiographic study revealed multiloculated cystic lucencies in the left hemithorax with associated rightward deviation of the mediastinal structures. Paucity of the rest of the bowel gas is also noted. Considerations for this case were congenital diaphragmatic hernia versus congenital cystic adenomatoid malformation. An ultrasound was performed on the left hemithorax, wherein a longitudinal sonographic image revealed the presence of non-reducible bowel loops above the spleen at the level of the left hemithorax. Ultimately, the left kidney was also observed to be positioned superiorly in relation to the spleen. Based on a study made by Rodriguez et al., the characteristics of a true thoracic ectopic kidney include irritation anomaly with its hilum facing inferiorly, structural abnormalities such as lobulated or deformed in shape, a long ureter, and medial deviation of the lower pole of the kidney. These observed findings are consistent with the sonographic images of the left kidney of our patient. After considering the aforementioned findings, contrast-enhanced computed tomography scans of the thorax and abdomen were performed. In coronal view, the CT image revealed a left-sided diaphragmatic defect through which gas-filled structures herniated and occupying most of the left hemithorax. Additionally, the spleen was intact and noted inferior to the left kidney. The displaced left kidney was seen within the thoracic region above the area of the diaphragm. These findings confirm our diagnosis of a rare case of intrathoracic renal ectopia with congenital diaphragmatic hernia. Ectopic kidney refers to a kidney located at any site other than the renal fossa. Most ectopic kidneys are found in the lower lumbar or pelvic region, secondary to failure of ascent during fetal life. Congenital thoracic kidney is presumed to be caused by accelerated cephalic migration or delayed formation of the diaphragm. It accounts for less than 5% of all renal ectopias, and its association with a congenital diaphragmatic hernia has been reported to have an incidence of only 0.25%. Intrathoracic ectopic kidney is not always associated with a diaphragmatic hernia. It has been classified into 4 subtypes with different associations and approaches to management. Group 1 is associated with a closed diaphragm, Group 2 with a diaphragmatic eventration, Group 3 with traumatic diaphragmatic rupture, and Group 4 with a congenital diaphragmatic hernia. The first 2 groups are usually asymptomatic and have a benign course, while the other 2 are often symptomatic and would require therapeutic intervention. In our case, the patient is classified in Group 4, hence surgical intervention was performed. A thoracic ectopic kidney has been reported to have ureters and renal vessels that are significantly longer than the normally positioned kidney. In surgery, it allows the reduction of the ectopic kidney into the abdominal cavity without hemodynamic impairment. The surgery of our patient was successful without immediate postoperative complications. Postoperative radiographic imaging now shows bowel gas within the abdominal cavity. The patient was then discharged on the 14th postoperative day without oxygen supplementation, but due to the ectopic nature of the kidney and the lack of studies regarding its long-term outcome, the patient was advised for long-term follow-up. And that concludes my report. Here are my references. Thank you and have a good day.
We are approaching the end of our case competition. We still have a few cases to go, so stay tuned. Next, we have from Malabar Medical College and Research Center in India, Dr. John Paul Davies will present a rare case of visceral fungal infection.
Hello everyone, my name is John Paul Davis, a second-year radiology resident at Malabar Medical College in Kerala, India. I would like to thank my mentor, Dr. Nawab, Dr. Bipin, and Dr. Gomati. I'm presenting a rare case of a visceral fungal infection in a 6-year-old boy, gastrointestinal basidiobulomycosis, and I have no disclosures for this presentation. The patient was an immunocompetent 6-year-old male who presented with fever, abdominal pain, and prolonged fatigue for a period of 1.5 months. During this time frame, he also experienced a weight loss of about 3 kilos. On systemic examination, a palpable mass was felt in the epigastric region and right hypochondrium with few palpable lymph nodes. He gave a history of COVID infection a year ago, and during this time frame, he had recurring fever, cough, and monthly nebulization episodes. His family history was significant for contact with a paternal uncle who had a diagnosis of tuberculous meningitis. He was started on antibiotics, however, this did not relieve his symptoms. His lab investigations showed a leukocytosis of 22,300 per mm³ with a predominance of neutrophils. He had elevated ESR and C-reactive proteins. His hemoglobin was 10.2 gram per deciliter. He had normal renal function and normal platelet counts. A blood culture did not reveal any organism. So a contrast-enhanced CT scan of his abdomen was done, which showed the following images. On axial section of his arterial face and portal venous face showed a heterogeneously enhancing lesion in the epigastric region that was centered in the mesentery with central area of necrosis. The adjacent bowel wall was thickened. This thickening was seen in the ascending colon as well as the hepatic flexure. And it was for a length of about 6 centimeters with maximum thickness of 15 millimeter. There was associated pericolonic fat standing. There were also a few enlarged retroperitoneal lymph nodes. The coronal section of the venous face helps us to appreciate a large conglomerated necrotic lymph nodal mass centered in the mesentery, as you can see here, and also the adjacent bowel wall thickening. A sagittal section of the venous face shows us the segment of the bowel that was thickened. Patient's course in the hospital was he was admitted with abdominal pain, fever, and he was started on antibiotics. However, this did not relieve his symptoms. And the CCT abdomen
showed a conglomerated necrotic mesenteric lymphadenopathy and bowel wall thickening. So he was suspected to have tuberculosis infection, and on testing, he happened to be negative for TB. So we suspected him to have melioidosis, and his antibiotics were changed. However, this did not improve the patient's conditions. In fact, it worsened, and he complained of increased abdominal pain and other symptoms. So he was advised to get a biopsy, which showed the following image. There was fungal hyphae as well as splendor-Hopley phenomena, which was diagnostic of basidiobolomycosis. He was started on antifungals, and unfortunately, his condition worsened, and he was admitted to the intensive care unit, and he unfortunately passed away. The final diagnosis was gastrointestinal basidiobolomycosis. Basidiobolomycosis is a rare infection. It usually causes chronic subcutaneous infection, and it does not cause a gastrointestinal infection commonly. It is caused by Basidiobolus rhananum, and human infection is quite rare. Gastrointestinal infection occurs by eating contaminated food, soil, or animal feces. It can be found worldwide. However, it's mainly reported in the tropical and subtropical regions. In the US, it has been reported in the state of Arizona. On imaging, the small bowel and solid organs are rarely involved. Usually, the large bowel is more frequently affected, and it manifests as bowel wall thickening along with abdominal lymphadenopathy. This leads to a commonly being misinterpreted as tuberculosis, inflammatory bowel illness, or cancer. So it is important for radiologists to keep in mind the diagnosis of gastrointestinal basidiobolomycosis when a patient presents with similar symptoms and similar imaging findings, thus to prevent any fatalities from these infections. These are my references. Thank you.
So we're approaching the end of this case competition. Before we go on to the last case, we're going to remind you that when this case finishes, we will put the poll so that everyone can vote for their favorite case. This is while the judges deliberate on the best cases of the night. So lastly, we have from Davao Doctors Hospital in Philippines, Dr. Ella Julien Eralino, presenting congenital pouch colon.
Good evening. I am Ella Jillian A. Aralino, a radiology resident at the Davao Doctors Hospital in the Philippines, and I will be presenting a case of a congenital pouch colon. I have no disclosures. This is a case of a 23-year-old male with chronic diarrhea and abdominal pain since 2 years old. Consults with different physicians were done, however, prescribed regimens provided no relief. Financial constraints limited regular follow-up, baseline imaging, and promoted tolerance of the condition. Consult in 2010 noted a fistula in the sacral region where fistulectomy was done. By 2018, he was referred to his current physician where laboratory tests showed elevated inflammatory markers and was seen to be underweight and short in stature. He was managed as a case of Crohn's disease and initially given mesalazine. Eventually, he was enrolled in a clinical study and prescribed with anti-TNF medications. By 2020, he was on vedolizumab infusion cycles, and upon completion in October 2022, there was interval symptom resolution and gradual weight gain. This prompted surveillance studies through colonoscopy, which showed multiple polyps within the colon and the scope advancing only up to the 35 cm level. Biopsy showed tubular adenoma with mild dysplasia. These findings prompted further imaging through CT enterography. Patients with Crohn's disease typically show aphthous and deep ulcerations with a cobblestone pattern, skip lesions, mesenteric involvement, and fistula formation. However, patient CT enterography showed the sigmoid colon connecting at the middle third of the transverse colon with the blind-ending left lateral segment lined with multiple polyps. These, along with the fistulous tract extending posteriorly to the dermis at the pelvic region, coincided with the congenital pouch colon. This is a large bowel malformation where segments or the entire colon show dilatations in the form of a pouch. Cases are associated with cutaneous and or urogenital system involving fistulas. Pathogenesis and embryology is poorly understood. Currently, the more widely accepted hypothesis is the vascular insult theory, stating that the malformation is due to varying degrees of vascular insult during the partitioning of the cloaca by the urogenital septum. Several reports of varying pouch configuration with abnormal vascular supplies support this theory. Most of the available literature only involve diagnosis amongst newborns presenting with poor bowel movement. Reported cases more frequently involve males with a 4:1 distribution. Case reports of diagnosis in adults are rare. The following list shows the characteristics and published cases with the following findings seen in our patient, which include the presence of anorectal malformation, a short and large bowel length, the pouch wall abruptly connected to a normal bowel segment without a transition zone, absence of gaustration, stenia, and appendices epiploicae in the pouch colon, and an abnormal vascular supply to the pouch. Although there are several variations to this condition, a widely accepted classification is based on the length of normal colon present proximal to the dilated pouch. This was first introduced in 1984 and was recently modified to include the fifth type, a double pouch colon with a short normal interposition colonic segment. The typical configuration in the patient's case would not fall under a definite category in this system. In most reports on neonates, plain erect abdominal radiographs are used to diagnose, showing a grossly dilated air fluid bowel loop occupying the abdominal cavity with small bowel displacement. Although plain radiographs can suggest the type, its definitive diagnosis is done intraoperatively. Here, the patient underwent CT enterography, a modified abdominopelvic CT scan technique done to examine small bowels in detail and to assess extent and severity of inflammatory bowel diseases. Neutral oral contrast and enteric phase CT is combined to optimize contrast resolution between mucosa and lumen. Non-invasive techniques such as this or MR enterography may be done as an alternative to invasive intraoperative measures for diagnosis. Finally, for treatment, pouch colon cases are managed surgically based on the pouch type present. It usually is done as a two-stage procedure, the first part being fistula ligation, typically followed by an abdominoperineal pull-through, which offers the safest option. In the patient's case, only fistulectomy was done. The intention of surgery is to evaluate the amount of large bowel affected and to salvage its maximum length to restore or partially restitute bowel function. In summary, a congenital pouch colon is a rare malformation that should be considered as a differential diagnosis in patients presenting with a similar clinical history of chronic diarrhea, known to have a form of fistula, and with no history of other surgical interventions. Radiographic imaging, visualizing bowel configuration, is an alternative, non-invasive method that could aid in its diagnosis prior to undergoing invasive procedures. Radiologists therefore play an integral role in the diagnosis and management of this malformation. These are my references. Thank you for listening.
Okay, now we're going to proceed to voting for the People's Choice Award. You will see a poll showing on your screen, and we will be back in 10 minutes with the judges' deliberation of the best case.
I think we're ready. Sign out. Ooh, we're missing Farouk. We cannot really get started without him. Ah, he's here. All right. Before we get going with the winners, with the announcement, please allow me to one more time say thank you to all of the of our global team. Thank you, Alejo and the Center for Global Health from the School of Medicine, to Farouk and Company for doing all the support and the website, the organization, the invitations and everything. And in the shop side, you see everyone here on camera. So thank you all for staying late on your Friday night to help us put together, again, the 7th edition of this competition, which is now the 3rd year, right? So once again, thank you very much. Now, of course, we also need to thank not only the support that we get here at home, but the 200 participants that we have online right now, enjoying these cases with us and learning through this experience with us. So again, thank you very much. And Farouk, what do you have to say?
Yeah, no, this has been great. You know, every year we continue to you know keep this up. I think is impressive. Much love to the group for coming back every year to get it done again. It's as exciting every time, and we feed up the energy of the audience, and the effort people put into their cases is quite impressive. So you know, great to spend the last couple of hours with you guys, and I think we're ready to announce some winners.
One last thing before we announce the winners is to please fill the survey at the end. We need some feedback, things to improve, things to change, and how to do better for when we come back next year. So that's an important reminder. After that, I think that we are now ready. I'll get us started because, oh no, you get us started because with the third place winner, I think that's a really good case, and that we were talking about right from the start. So,
all right, third place winner is Dr. Lamle Trankan from Vietnam with a case lung cancer resembling pneumonia. Third place winner, who gets $250. Yay!
And bragging rights. All right, and for the second place, I think this was probably my favorite case, Dr. Jasrel, with a Chiari-2 malformation and an anterior thoracic myelomeningocele from the Philippines. So, Dr. Jasrel, you're the second place, and again, $500, and most importantly, some bragging rights and a certificate to add to your CV that you happen to run across an awesome case and took advantage of it to teach us all about it. Thank you very much. And now we're gonna go back to the People's Choice Award, right?
Yeah.
The people, okay, you go ahead and do it. I don't know how to say all those words.
Right. The People's Choice Award goes to Dr. Abdurrahman, Biotinase deficiency, Dr. Abdurrahman. And the People's Choice gets $250, and known that you're a person of the people.
That was a good case from Lahore. Like, yeah, nice case. All right, and that leaves us with the first place and winner. That is what we came for here. Is Dr. Hanina from India with a patient with ovarian cyst and bone lesions, McCune-Albright syndrome. So awesome case, awesome presentation, great imaging. Overall, the winner of the night. So thank you so much, Dr. Hanina.
Congratulations.
We are going to share these winners in writing because we know that our pronunciations and of both titles and names is not great. So here are the winners. Congratulations to all. And we are going to alternate this slide with the winners with the code for the feedback survey. You can do that, Mohammed, right away. Please fill the feedback. It's important for us to know how do you think we're doing and what we can, again, do better for next year when we will see each other again. same time, same channel. Okay. And with that, thank you very much, guys.
Thanks everyone who showed up, and congratulations for the winners. These are the winners once more, just sharing the slide for those who didn't hear the first time. And please don't forget to leave us some feedback. In the QR code, you can see it on Dr. Monica's screen as well. And here it is.
And with that, we leave you to enjoy the rest of your weekend. Congratulations.
Congratulations. Expect an email from us with the certificate of winning or of participating. And of course, we will follow up with the winners for the prizes. Thank you, everyone. Goodbye.
Have a good day.